Okay. Good afternoon, everyone. Welcome to today's SEAside webinar, Preparedness and Response for Public Health Emergencies, the mission of the Assistant Secretary for Preparedness and Response. My name is Amy Gogan. I'm the Data and Evaluation Coordinator for the Southeastern Atlantic region. Before we begin with today's guest speaker, there are a few administrative things that I'm going to run by you all. We have a few questions that I've put in the slide before the start of the webinar if you'd like to answer them. If you want to share any activities you've done or resources you've utilized related to disaster preparedness, please feel free to share those in the chat box. Also, as you're sharing, communicating, and asking questions in the chat box, please be sure to send to all attendees so that the guest presenter, your colleagues, and I can all see your questions or information that you've shared. We'll also have time for questions at the end of the presentation. If you need closed captioning, I'm going to put the link to that in the chat box right now. And we'll get started with a short bio, and then we'll get started with Dr. Korch's presentation. So George W. Korch Jr., PhD, is currently the Senior Science Advisor to the Assistant Secretary of Preparedness and Response at the U.S. Department of Health and Human Services, a position that he's held for much of the time up to the present since 2009. He also served during 2017 as the Acting Assistant Secretary for Preparedness and Response and as the Acting Principal Deputy Assistant Secretary for Preparedness and Response in 2011. Dr. Korch helped to coordinate and oversee the U.S. government's public health emergency medical countermeasures enterprise at HHS. He participates and/or leads on a variety of national and governmental committees under the auspices of the White House's National Security Council and the Office of Science and Technology Policy. He's also the co-chair of the Federal Expert Security Advisory Panel to the National Security Staff, as well as chair of the Federal Security Laboratory Facilities Inventory and Communications Working Group under the auspices of the White House National Sciences and Technology Council. Dr. Korch has been a visiting professor in the Department of Molecular Microbiology and Immunology, Johns Hopkins School of Public Health, and he retired from the U.S. Army Medical Department in 2008 with the rank of colonel. He's also served in many leadership roles while in the Army, including commander of the U.S. Army Medical Research Institute of Infectious Disease and the director of the Department of Defense Medical, Chemical, and Biological Defense Research Programs. He's authored a number of peer-reviewed journal articles and co-authored a book on medical countermeasures for biodefense, and he served on committees including the National Academy of Sciences, Institute of Medicine's Forum on Microbial Threats, and Maryland's Life Sciences Advisory Board. His training was in medical entomology, immunology, virology, and infectious diseases, with his PhD awarded from the Johns Hopkins Bloomberg School of Public Health. I am so pleased that he has agreed to be with us today. Thank you so much. So everyone, please welcome Dr. Korch, and I will hand the ball over to you right now. It should be ready to go.
Thank you very much. Thank you, Amy. A pleasure to be here. Wow, I'd like to meet that guy. There's a lot of stuff there. As I look back, I think, yeah, that happened over a period of time, but I'm really happy that I'm able to come to you today in my current role as a Senior Science Advisor. So we'll discuss a bit about what ASPR does and the various elements of how we handle preparedness and response activities. And I'm going to figure out how to advance the slides right here, Amy. I think I just do a backwards and forwards, or I think I practiced this once before, but now.
You should be able to just hit the little caret to the right of that little box above the slides. It says a three inside of it. Do you see that?
A little caret with a 3 inside of it.
The 3 is it's in a box, and then there should be a caret to the right of it.
Okay, looking.
Do you not see that? Okay.
I don't see a caret box. Okay.
Okay, I'll advance for you, and then I'll see if I can see what's going on.
Very good. Okay. So next slide, please. Oh, I see a 3. I got it. All right, got it. I see what you're talking about in terms of the 3. Yep.
Okay.
So there we go. Anyway, all right. I've been with ASPR, as Amy said, for about 10 years now, and over that course of time, we've responded to a variety of different events, large-scale biological and public health events, like the 2009 H1N1 pandemic. In 2013, we were looking at MERS-CoV, Middle Eastern Respiratory Syndrome virus. Of course, in 2014 and this year in 2017, there's Ebola in Africa. And in 2015 through 16, we saw Zika virus in the Western Hemisphere. We respond to natural disasters, things like Hurricane Harvey, Irma, and Maria last year, Superstorm Sandy back in around 2012, earthquakes and floods and nuclear power disasters. We were part of the response to Fukushima Daiichi event happening in Japan a number of years ago, but also man-made disasters, Deepwater Horizon, if that comes to your remembrance, and more recently, responding to things like cyber attacks on our healthcare system. So what this really says is that almost all of these large events have a public health or medical impact or have consequence somewhere along the line. And realistically, the future holds yet more surprises in store when we think about chemical, biological, radiological, and nuclear or natural threats, as well as potentially newly emerging threats from infectious diseases or maybe even genetically engineered pathogens. So we live in a world that's got a lot of dangers, but on the flip side, there are a lot of things that have gone well, and biotechnologies are moving us forward in ways that also will be able to address some of these threats. Now, ASPR was really created in the wake of Hurricane Katrina, and it was created under legislation called the Pandemic and All Hazards Preparedness Act, or PAPA. And it really was meant to lead public health and medical preparedness for the country to respond to these types of disasters. It was modeled in a way after the Goldwater-Nichols Act, which was designed to create a unified command structure for the Department of Defense, so bringing all the various branches of the military into a single chain of command and improving communication. So that was Congress's intent when ASPR was created in 2005 and 6, to be a unified effort, to be dedicated to a public health and medical response capacity for all hazards, and to integrate these elements into an effective response so that there's one command structure with a common purpose and a common vision. Since that point, ASPR really has evolved into an organization that collaborates with a variety of stakeholders: hospitals, healthcare coalitions, biotechnology firms, communities, states, local, tribal, territorial governments, and a variety of other partners across the country and internationally as well to really improve capability. So ASPR's mission is quite simply stated as saving lives and protecting Americans, so the population in the United States, from 21st century health security threats, and the types I've already mentioned. And when we look at what this means, I mentioned already the list of various kind of conditions we responded to, and you see above that timeline sort of the policy investments that have happened. We talked just a moment ago about the Pandemic and All Hazards Preparedness Act, but there have been a variety of other policy documents and authorizations along the way to empower ASPR to be able to carry out mission. More recently, and very soon, probably next week, you'll hear about the release of the National Biodefense Strategy from the administration. We've been working on this document for almost 2 years, and it lays out in one specific area in biodefense the various types of elements that the U.S. government has to be able to carry out, and ASPR will be key in terms of oversight of that strategy as well. So each one of these events on the bottom has stimulated sort of a call and response with regard to capability that has been authorized by Congress. And we really operate under all hazards principle here. And so the things that we learn as we work for responses or medical products or chemical, biological, radiological, and nuclear threats also have application when we look at other kinds of needs, for instance, seasonal and pandemic influenza preparedness, or when we look at what the future might hold with regard to newly emerging diseases and preparedness there. The other aspect that you'll hear me talk about is not just all hazards principle, but how we look at these things from the life cycle management, full life cycle management of the products, from requirements, what do we need, what types, for how many, and how are we going to use them, all the way through research and development, licensure, stockpiling, and ultimately use of the end product at the patient-provider interface. ASPR really has set a variety of priorities for building this readiness for the next century, for this century. And so the overarching themes that you see here are hearkening to the intent for very strong leadership across the federal government in this particular domain in public health and medical response. To be able to develop, and I'll talk a little bit about the regional disaster healthcare response system, so an immediate ability to mobilize for a response to augment state and local capacity. The medical countermeasure enterprise, and I'll spend a good deal of time on this, to be able to create these products that we need for very specific threats. And then finally, just public health security capacity, what other things need to be part of the environment so that we can address not just the knowns, but have flexibility for some of the unknowns as well. Getting into just the emergency response capabilities, the ASPR oversees operations for the Health and Human Services Secretary's Emergency Operations Center, which is a center that's active 24/7, 365 days a year. And it ties in with the other national operations centers in other departments. So HHS is charged with oversight of something called the Emergency Support Function number 8, which is the public health and medical response within the framework of the National Response Framework. And our SOC, or the Operations Center, helps to communicate to stakeholders nationally and internationally based on the nature of the type of response, or the type of things that we need to do. So the ASPR also oversees continuity of operations for people in government. You'll understand a COOP, continuity of operations, takes place when we have to potentially abandon locations here in the DC area and operate out of a remote site. So we also have oversight for how the Department of Health and Human Services plans and activates and uses those locations. We also plan for many other types of events. Now, this requires constant investment in people, in facilities, medical materials like medical caches. So there's an extensive investment in resources and logistics. And then finally, we have built over the course of years the National Disaster Medical System. And this is comprised of a large number of teams located across the states and within FEMA regions. And they're configured to provide from days to several weeks of augmentation or accessory medical response capability to help in the loss of local capacity or local capability during those short periods of time. So we have the DMAT teams, the medical assistance teams, that provide health and medical response. We also have several national veterinary teams that provide similar kinds of support to veterinary populations. There are DMORT teams, or mortuary assistance teams, and they assist the jurisdictions themselves or other local needs at the coroner level when there's been an overwhelming level of mortality for an event. In addition to this, the ASPR also oversees the Medical Reserve Corps, which is a network of U.S. community-based units that are established by local organizations to meet these public health needs of the communities. And this program comprises thousands of people, a wide range of medical and administrative expertise. So you can think of physicians, dentists, nurses, pharmacists, paramedics, and then other public health or medical professionals, public health workers, mental health practitioners, trainers, other administrative support personnel as well. So literally thousands of people participate in the response at that level. The other aspect of the emergency operations here are for preparedness in terms of resilience at the community level. So I mentioned already the Medical Reserve Corps volunteers comprising over 200,000 individuals that have to be coordinated. But we also provide monies to states through the Hospital Preparedness Program grants. That supports 62 states, and these are awarded to local healthcare coalitions of hospitals and other providers within those localities. We actually work very actively with the FEMA regional coordinators. We embed our own medical experts in those regions for those responses. And to support all of this, we have now a training center in Anniston, Alabama, that helps keep the skills sharp for people within the NDMS. So these are both individual skill sets and team-level training opportunities as well. And then we do have, fortunately, a large outreach to groups of subject matter experts and capabilities that can assist at local levels in terms of response and recovery phases of operation that can be deployed when needed. So I think that's going to cover, for the most part, just a quick flavoring of the emergency operations within ASPR. And what I want to switch to right now is the medical product development components of what ASPR does, and touch on a little bit of what the public health emergency medical countermeasure enterprise is in terms of assistance in coordinating all those responses or those capabilities. So this is just some things that I took out of local headlines over the last several months, and it really addresses biodefense. And biodefense is a major element of our planning and response because of the nature of infectious diseases, which changes over time, and because biotechnological advances create both opportunities to benefit mankind, but also create some unique potentials for harm. Now, while we don't tend to think about things like antimicrobial resistance as a biodefense issue, it actually is part of how we look at the dimensionality of the threat. So the range of needs that might confront us nationally and globally in terms of health security, and that's what biodefense is all about. What types of things must we think about in terms of our own health security? And certainly having or losing a capability to have effective antibiotics to treat community-acquired infections, as I'll show you in a later slide, enters into the consideration for biodefense, just as do these other things that you see there. Global defense market growing as a threat of bioterrorism, the synthesis of horsepox virus a few years ago by some of our collaborators or colleagues up in Canada, intended originally to demonstrate the ability to construct the full-length orthopox virus from synthetic underpinning. And of course, horsepox is a virus unto itself, but the implied threat here also is that, well, if we can construct horsepox, somebody could probably construct smallpox. So that caught the international attention. And then recent exercises run in DC to look at how would the U.S. respond, or what would be ostensibly the type of concerns should we see a bioengineered pandemic threat that sweeps not just the United States, but sweeps the world. So a lot of considerations there on how the U.S. government at the cabinet level would deal with those types of events. So biodefense has been in the news by way of some of the exotic types of things described in that slide. But it's also in the news, and with apologies, because this slide is now a little bit dated by the fact when I first put it together, it was during the spring, and the DRC had a particular event in the western part of the Democratic Republic of Congo. But that's been replaced by yet another outbreak in the eastern Democratic Republic of Congo, or in the Kivu area, where the situation now comprises about 124 confirmed and suspected cases of Ebola, including a classic high case fatality ratio and impact, once again, on local healthcare workers. And here we have a threat that is just a biodefense problem that we've thought about for years, but unlike the spring event, this one's taking place in a much less politically stable location, which creates its own difficulties in terms of how to provide assistance and support. But in this context, we've mobilized vaccines and therapeutics. A number of these have been developed by ASPR and others, Department of Defense and NIH and CDC, to impact this outbreak. And you can see from this particular slide, this is a historical reference of all the various outbreaks that we've seen from Ebola virus in this region of the world since 1976. So the take-home message here should be, when these events happen, they shouldn't take us by surprise. They're just part of the natural ecology of these locations, and but still with international travel being what it is, the world getting to be a smaller place, more connectivity, events that in 1976 were seen as pretty exotic and remote are now considered to be a lot more immediately of concern. And as you recall, the events of 2014, the world watched as much larger population centers had to deal with Ebola and then consequences elsewhere as cases were transported from Africa and into other countries. Okay, so let me turn quickly then to medical products, because I've mentioned them a few times. So what does it really mean to make a medical product? We call this the hurricane chart in a sense, and all it basically says is that in order to get one licensed product, generally you have to start off with a whole lot of candidates somewhere way back in the pipeline of concepts about how to deal with a particular issue. And what you see here is over time and at great expense, you start de-risking because you eliminate things that just don't work out. Maybe they're not efficacious, maybe they got other safety concerns or production concerns. But through a series of multiple steps and many years and dollars invested, and at this point I think the overall estimate is the average amount of money spent on a medical product for moving from concept all the way up to licensure is about $1.3, $1.4 billion. So very expensive and very risk-laden. The other thing that this slide is meant to show is that it takes a number of years to get there, that there has been traditionally this area in the middle called the Valley of Death, where the types of research needs become much more expensive as you're putting them into clinical trials and large numbers of people, and these types of studies can run from tens of millions to hundreds of millions to perform. But the other important aspect of this slide is as you look at the phases from discovery out to production and delivery, we have a way in this government of dividing the principal actors or responsible partners across this timeline or phase line. So early on within Health and Human Services, we think about NIH and CDC as providing some of the backdrop on early stage candidate development. And the same thing happens in the Department of Defense at places like Medical Research and Material Command. But as things mature, BARDA was really developed or designed to address this valley of death prior to BARDA's existence. This was largely uncharted territory, and you kept your fingers crossed that maybe some commercial partner would find an interest in a product you're developing and move it to licensure. And that was addressed through, the POPR legislation, as well as something called Project BioShield, to provide 10 years worth of funding starting back in 2003 and running to 2013, and there have been subsequent amounts of money provided. But this is an advanced outlay of about $5.6 billion that industry suddenly recognized as a real serious approach by the United States government to make these products move forward. So as they moved forward and got procured, once they met their milestones, they were picked up and placed into the Strategic National Stockpile. So this very complex slide just tells you that very expensive, very risky, very lengthy, and that there are multiple agencies that have to deal with this. So complexity is the name of the game in terms of making medical products. And how did we address that at the federal level? Well, we engaged all these organizations in something called the Public Health Emergency Medical Countermeasure Enterprise, or we call it FEMC for short. And on that inner circle, you see the full life cycle from setting the requirements and all the way through as you go clockwise to how these products ultimately, once we've procured them and distributed them, how they get used for the patient's benefit. And the agencies within HHS that are responsible for that slice of the pie are in the blue. And then in the outer green circle, you see the other federal agencies like Department of Homeland Security, USDA, Department of Defense, the Veterans Administration that have component or equivalent needs and represent another part of the stakeholder or part of this whole landscape of the FEMC. So we pull all these people together, and in that gray area outside of the circle is the rest of the stakeholders, the public, state and local governments, industry, academia, and professional societies. So this is the active model that we've used to be able to bring or move these products forward. So when I mentioned requirements, what does that look like? So the FEMC, by law, focuses on very specific conditions and pathogens that have been previously recognized in this formalized process as national security risks by the Department of Homeland Security. So they take other information, maybe intelligence information or other materials that they have at their disposal to identify what specifically could cause very large-scale public health events in the United States. And they issue something called a material threat determination. You can see the types of threats on the very far left and when the MTDs were issued. And that is the starting point for HHS to be able to then say, all right, we're going to start pulling together what we know about plague and figure out how we're going to make medical products for plague. So what kind of products might we need for plague? Well, probably because we don't immunize people for plague generally, we'd be looking at an event that happens afterwards, and we would need antibiotics or maybe a monoclonal antibody. So every one of these particular pathogens or conditions that you see, we do an in-depth public health assessment for what's necessary to treat populations at what size level based on what kind of scenarios, and then are there special needs for special populations like for pediatric populations or immunocompromised populations that can't be met by just a general approach for adults, let's say, or for people that are generally healthy. And how well have we done over the course of the years in terms of these investments and kind of peeling back where our risks are? Well, in the green, you can see that those are agents for which we're very, very comfortable. We have been able to develop and supply and now have at our disposal a large stockpile of materials to deal with those types of threats. Of course, we could never have enough money and time to do everything simultaneously, so the things that you see going clockwise around, botulinum and radiological events are in pretty good shape, and we have some components for nuclear and for nerve agents, but as you move out, there's Ebola, there's Marburg, making progress. I'm thinking those are starting to turn from that kind of orangey color to a more yellowy color. But we still do have a lot of challenges on some of the chemical threats just because of the complexity of dealing with a very rapidly distributed or delivered threat for vesicants and cyanides and chlorine. But this is a demonstration that over the course of the years, there has been progress on present threats of things that we have been concerned about. And so most of this happens because BARDA has been responsible for assuming the mantle and moving some of these products forward by working with industries, which has been a key aspect of some of the success that I'll show you in a minute. So BARDA's priorities right now in that all-hazard space that I showed you before on things like better and faster flu vaccines, maintaining and expanding a domestic manufacturing capacity for flu, and not based solely on eggs. So we are looking at a number of different mechanisms to produce recombinant vaccines and vaccines that are done in cell culture, novel adjuvants, et cetera. And to sustain the products made under those Project BioShield procurements that I talked about before, and making sure that we've established this market guarantee to industry that was a part of the original architecture under the reserve fund that you see here, that SRF. We're also committed to, BARDA's committed to looking at things like the gaps still in preparedness for chemical agents, drug-resistant pathogens, and to that end, CARB-X, which I'll have a slide on, addresses the impending or the expanding concerns with regard to antibiotic-resistant bacteria. And then finally, I'll talk a little bit about launching a brand new, I guess, initiative called DRIVE, which stands for the Division of Innovation and Venture. So I'll cover all those here in the next several slides. So what's the demonstration that we have been successful? Well, this is a timeline of FDA approvals, licensures, and clearances for a variety of products over the 12 years that BARDA's invested. And you can see this steady portfolio of licensed products to address these threats. Now, as you look, many of these earlier products were aimed at influenza, at advances within influenza, and that's partially due to a real concern back in 2005 about H5N1. But recently, our long-term investments have paid off for successful products for anthrax and smallpox and conditions like acute radiological syndrome, for anticonvulsants, for nerve agents, and now we're beginning to see new antibiotics that are coming to market through licensure of some of the investments that have been made recently. So this is a list, a very impressive list of approvals that BARDA has had a hand in. And along those lines, at this point, the tail of the tape has been, we've supported, BARDA supported successfully, I think 40 different products through licensure or through approvals with FDA. And this is not just reflective really of the efforts at BARDA, but it's really a concerted effort by our other colleagues, notably, very importantly, the Food and Drug Administration, and then CDC and NIH, and the Department of Defense has been very active as well in doing some of the basic studies or providing other assistance as these products move on through. But I'd be remiss if I didn't point out the huge impact that partnerships have with regard to our industrial partners. And BARDA has spent a lot of time nurturing those relationships because those partners ultimately bear the brunt and the responsibility for the work that goes into all the components of making those vaccines and drugs and diagnostics and moving them through licensure to the FDA. So we're there to help them through this, but they really are the keystone for how these successes happen. So here's just one example of something recently. This is the drug called TPOXX or tecovirimat. It was initiated as a potential treatment for smallpox as far back as I think the late 1990s, early 2000s, and it engaged the efforts of CDC and the U.S. Army Medical Research Institute of Infectious Diseases. Way back when I was the commander there, I remember some of this work going on. But also our industry partners from SIGA Technologies, just to take one example, who demonstrated through its efforts the efficacy in animal models of orthopoxvirus infections, and through many years of data gathering and studies to demonstrate the safety of the product in humans and animals, as well as performing surrogate studies for efficacy against smallpox by using other similar orthopoxviruses in animal models. So this is something called the animal model rule. It was a way that we were able to provide or create a medical product for smallpox, which doesn't, of course, exist anywhere in the world. It was eliminated or eradicated back in the late 70s. And so being able to demonstrate to the FDA that you have a product specifically intended to be efficacious against a now, quote, extinct virus is required a variety of other ways in the regulatory realm to be able to demonstrate safety and efficacy. So this is another success story because we were able to use these authorities that FDA had for these unusual circumstances to get approval. And it represents also a major commitment by the United States government to fulfill promises that we've made both nationally and internationally to be able to develop products of this sort. Because if we were to ever see smallpox show back up again, and of course I mentioned that horsepox experience a few slides back, if we were to ever see this again, the world would need these kinds of products to be able to instantly respond. As I kind of wrap up some of the work here that BARDA does on a routine basis, I did mention the diverse portfolio for the persistent threat of influenza. Influenza on an annual basis affects or kills, I think we have between 12,000 and about 25,000 cases of deaths annually in the United States due to influenza. And BARDA has made these very substantial investments in vaccine production. So we've increased the number of, the number of doses of vaccine that are produced in this country for influenza. And they've also invested in much more rapid diagnostic testing for point-of-care capability. Treatment has been a little bit harder. It's a bit more of a kind of a complex need for developing new antivirals. But recently, for instance, there's a new thing on the market. Most of the current influenza antivirals are based on neuraminidase inhibitors that essentially block release of mature viral particles from the cell surface as they mature. But a new drug that is designed in Japan is called Xofluza, is a different mode of action using a cap-dependent endonuclease inhibitor for all you scientists out there. And the developer, Shionogi, has been initiating some of the discussions with BARDA, so we'll be looking at the way to fund new trials for new therapeutics and see if we can't somehow increase our opportunities to have a new antiviral here for influenza in this country. Now, the BARDA model has been useful, or has been very successful, because they do spend a lot of time in public-private partnerships with industry, and here are some of the things that they've done to be able to work more effectively. So even though the science is important, just as important are the business elements of things. And BARDA has been able to use something called other transactional authorities to work with businesses the way that other businesses work with businesses. So rather than a very complex contracting process using the federal acquisition regulations, we have ways of working directly and much more efficiently with businesses to produce contracts and obtain work for things that we would like, but to do it in a much more flexible fashion, like sitting on a board of directors to discuss the types of products that the company may be working on and having influence on decisions that are made there by virtue of our investment. The multi-year funding that was provided by BARDA was another very big incentive, a pull program to be able to attract industry to the types of things that we needed. We are very interested in promoting innovation in these companies. That's been a big draw for these partnerships. And also we have a number of people at BARDA who have come out of industry, and because of that experience, we're able to talk the language with these companies so that they feel comfortable that we understand what they're talking about. And we've also developed in BARDA some other integrated capabilities for product development. For instance, although we don't control what happens to the Food and Drug Administration, just having a government partner to help underpin discussions with FDA is an important component of some of the successes, I think. We have a manufacturing infrastructure that we've built in these centers for advanced development for manufacturing, a couple of them around the country, and we can provide core services and support to these businesses for things like animal model development or fill and finish for products, because we have at the ready organizations that we can write a contract for and get products filled and finished if the manufacturer of our product does not have that capacity internally. So in these last couple of slides, I'm going to talk about where we're moving to in the future, what has been happening. So over on the left, you see all of these various threats. There's chemical threats and burns and radiation and flu and Ebola, smallpox, anthrax. And they all result in various outcomes, so respiratory distress, cutaneous issues, things affecting white blood cell count, fever. And as we develop these very specific products to address these threats, we have secondary issues that we have to deal with. And sometimes those are in the realm of opportunistic infections. So we treat people in hospitals or in other community locations, and that they now acquire opportunistic infections that are out there normally, and because in some of these circumstances they're immunocompromised or they're at they have some insult that reduces their ability to be resistant, we now can have the chance that we win the battle against the initial threat, but we lose the war against keeping these patients able to survive. And ultimately, if they go on to septic shock, everything that we've invested in is all comes crashing down because of other events and other kinds of responses that we needed to consider for these patients. So that was one of the rationale for why BARDA started to invest in antimicrobial resistant organisms. And our portfolio is and our ability to work with novel organizations, as you can see, the sponsors of these various the various new antimicrobial compounds. I think arabicycline for cupric tetraphase was just awarded. It says NDA submit. I think plazomicin also was just awarded a approval. And you can see that the biodefense profile is for very specific pathogens, and the commercial indications are for the types of things, you know, complicated urinary tract infections or other resistance mechanisms for soft tissue, et cetera. So it's a twofer. We get something for biodefense profile that also addresses a commercial application or a commercial indication or a real medical need at the community level. And CARB-X is the mechanism that we've used. This is a public-private partnership. We combined efforts with Wellcome Trust, invested about, I think, combined about $450 million between those two organizations. We work with a prime vendor, if you will, out of Boston University to scout the various opportunities out there in the marketplace. People apply for grants or for specific access to funds. And by the numbers you can see, we've had 20 different projects targeting various types of bacteria across multiple countries, new classes of antibiotics and new molecular targets. But we also expand to diagnostics and vaccines. And the most important aspect of this is that for every dollar that CARB-X invests, we're seeing about a 7.5-fold return from the private sector to secure those particular investments. And so that's a way to leverage public and private funds to achieve a net goal where everybody benefits from some of these investments. So the last little phase of this, I'm going to talk about this venture for research, innovation, and venture capital. And this is Drive, and it's brand new. And on the right you see sort of the componentry, which is kind of the early stage looking at what's out there in terms of technologies or types of opportunities that we may want to think about that are not really specifically related to a pathogen of concern, but have much broader application. And then developing a system to accelerate investments in key areas and ultimately to bring some of these much more tangible or more promising investments into a strategic sustainment by looking at venture capital, by actually doing what venture capital does, creating an ability to increase the level of investment through VC type of approaches. And so the response framework that we're looking at here for these kind of events pretty much follows what we talked about a little bit in terms of the, how we look at developing an end-to-end architecture, but identify and characterize novel types of issues, design what we might want to do to respond to those, validate that the things that we're thinking about are correct, and then being able to produce those things quickly and distribute them quickly so that we have a way to respond much more effectively to novel threats as they come on up. So what am I talking about when I say how are we really approaching this? Well, one thing is we have set up now these U.S. hubs of innovation that are going to help us look across the various opportunities in industry and academia to be our kind of feelers out there for if we say we want something that does X, Y, Z, these hubs of innovation partner with us to try to find, well, are there people out there that are making investments in this and with whom we should have conversations to really explore a bit more of what opportunities are out there. And our initial emphasis on Drive is going to be the following. We've started to engage in technologies to help solve sepsis, because you recall from that other slide, it's one of the key components that we worry about in terms of response capability. But we're also looking at something called ENACT, early notification, act, control, and treat. And these would be, think of these as wearable, pre-symptomatic diagnostic capabilities to help us determine, well, before you get a full-blown outbreak of, full-blown case of influenza, and at which point we may not be able to use our antivirals effectively, can we shorten the time frame that the physician has to be able to effectively use some of the medical products that we have. So these are some of our future areas that we've started to invest in. And then that little thing in the med box in down at the bottom there, I'll describe that in a minute for pharmacy on demand or priority medicines on demand. And with the remaining time I've got, a few minutes, I really won't talk about the general problem of sepsis other than to say it's a huge issue in terms of the cost to the United States for treating these populations. And what we've done is we've brought together subject matter experts in sepsis to look at, well, where are the touch points where we think BARDA can have a big influence to reverse or reduce by, let's say, even 25% the negative impacts of sepsis at the population level. And so in terms of looking at the failure points, we have identified in this particular area using the subject matter expertise that we will be investing in creating integrated national databases of patient outcomes, which will allow us ultimately to generate real-time analytics and prognosticative capability, and that hopefully will provide to the attending medical staff sort of moment-by-moment experience and a recommendation at the level of specificity of that patient, but based on information gathered from thousands and thousands of other cases. So that's one area that we see that we might be able to have some immediate impact in terms of the current failure points and current practices on sepsis. So let's see, I'm going to try to line this up with the last slide or two. Last slide, I think, is on something we're really looking at right now. This is a pharmacy on demand. We're going to have a summit here shortly, bringing together a number of other types of subject matter experts on how we might be able to reduce to very small footprints drug manufacturing, so that, think about it, almost in the equivalent of almost at the corner store, the drugs that you need can be manufactured there in a very short period of time. And that because it might be highly distributed, we may be able to reverse what we have currently or with regard to having to purchase and store large numbers of materials that may never get used. So we're looking at, is there another solution or another approach that we can have to provide these medicines that might be needed for instant availability or very short-term availability following an event. So where you can find us is online, publichealth.phe.gov, publichealthemergency.gov. You'll also find Drive on the web and some of these other components, social media, Facebook, YouTube, et cetera, and Twitter. And with that, I want to thank you for your time, and happy to take a couple of questions.
George, thank you so much for a fabulous presentation. So if anyone has questions, please put them in the chat box and I will relay them. We do have some time for questions. If anyone has any, please throw them in the chat box. I'll give you a second to think. Okay, so here's a question from Carolyn. She asks, how is law enforcement involved in ensuring security with expansion of the public-private partnerships?
Oh, great question. So we do work a lot with our law enforcement colleagues. For me personally, a lot of that is with Department of Justice and with FBI. And probably the best way to describe this is the nexus in terms of how they would respond to a weapons of mass destruction event. So I'm using WMD as kind of the discussion point or the opportunity. When or if we should have an event, the jurisdictions become clear under the sort of the emergency support framework. If it's a criminal event, the Department of Justice, FBI, forensics, et cetera, they are in control of the crime scene, they're in control of gathering information and evidence, but some of the evidence that they may need to gather is actually epidemiological evidence, and so they have partnered with places like the CDC and with us to try to identify in advance how the responses are going to run and who the central experts are. So at the national level for law enforcement, those are important. At a local level, intersect with our colleagues in law enforcement take sometimes a different form. Some of them may be part of a criminal investigation, but some of it is going to be in terms of mass control and support to a public health response. So think of what security measures and how the local community may require policing and other emergency response to be able to develop a distribution center to hand out pills, for instance, if we needed to do that. So as I said before, a lot of these things have a medical and a public health instant application. Many of them also have a concomitant response at the side of public safety and law enforcement.
Great, thank you so much. Any other questions for George? Don't see any more in the chat box. All right, well, again, thank you so much. I really appreciate it. Thanks everyone for attending today's presentation. Before we go, since September is Disaster Preparedness Month, I'd like to share some information from the National Library of Medicine Disaster Information Management Research Center, or DIMRIC. So make sure that you turn to DIMRIC for tools and resources on preparing for and responding to disasters. DIMRIC focuses on providing support to the disaster workforce, public health departments, emergency responders, librarians, and others who find themselves involved in disaster and public health emergency response efforts. Please check out their redesigned website if you haven't visited in a while, if you've never been there. A good place to start is with their information guides. They have guides on topics like hurricanes, floods, wildfires. You'll also find information guides on infectious diseases like Zika and Ebola. And there are also special topic guides including coping, children in disasters, and more. There is also the Disaster Lit database, which Siobhan mentioned earlier in the chat box. It is the database for disaster medicine and public health. It's the NNLM database of links to disaster medicine and public health documents. They're all available on the internet at no cost. They include expert guidelines, research reports, conference proceedings, and more. And finally, you can stay in touch with DIMRIC by joining their listserv, subscribing to email updates, and following them on Twitter, and also attending their webinars. They do have a webinar coming up on September 20th called Planning for Disaster. Partnerships ensure continuity of operations. You can find information on their homepage. So as a reminder, today's presentation was recorded and will be posted on the NNLM YouTube page as soon as possible. We'll also be posting a PDF of the slides and a link to the recording on the archive class page. I'm posting the YouTube link in the chat box right now. Our next webinar, the C region is hosting, is on Thursday, September 27th at 1 p.m. Eastern, titled Why Library Partners Are Critical to the All of Us Research Program. Details about registering are on nnlm.gov. And finally, to evaluate today's webinar and receive your MLA-CE credit, please visit this link, which I am posting in the chat box as we speak. I will also send it to you all once the recording is posted. And thanks again, everyone, for attending today's webinar. And I really want to thank you, Dr. Korch, for being with us today. It was excellent webinars. Thanks, everyone, so much.
Thank you very much. Take care, everybody.
You too.